Okay, so we kind of divided these talks. So I'm Ahmed. I'm one of the fellows in Toronto, doing orthopedic oncology, and we divided this amongst us, the three fellows here. There's John Pereira and Izu Ibe. We come from all parts of the world. If you want, I'm from Canada. Ibe, Dr. Ibe is from. He trained in Yale, and Dr. Pereira comes to us from London, UK. And we divided the talk in benign bone tumors, which I will cover very quickly with some case presentations, and then Dr. Ibe will present on bone metastasis, and then finally Dr. Pereira will present on sarcomas, soft tissue sarcomas, and osteosarcomas. Okay. So I thought these slides are all taken from Dr. Ferguson. So I thank him for his preparation of these slides. It made our lives easier, and it was well structured. And he structured the benign bone tumors in a kind of case-based presentation. I think it's a good way to go through the majority of these. And when we're first faced with these X-rays that are kind of impressive and we're not sure what to do, I think it just covers that in a good basis, and then we'll go over the main benign tumors. Okay, so in case one is a 19-year-old male who had basically a basketball injury, collided with another player. He heard a snap in his arm, in his left arm. He had severe pain, and then he presents to your office, and he has a complete radial nerve palsy. So you get X-rays. And the slides, there's a small delay here. Right?
That's okay.
So you get X-rays, and there's this lesion in the distal shaft of the humerus and a pathological fracture, obviously. So when you see this patient, obviously you want to try to figure out what's going on, what's the best treatment plan, and how you want to work them up to be able to be sent to one of your colleagues. So when you look at this lesion in more detail, there's some lytic regions and some bony expansion, but overall there's no real cortical irregularities, no soft tissue masses that you see on the X-ray. So that gives you an idea that this is more on the benign side of things. Okay, and this is a typical X-ray of actually a fibrous dysplasia with a fracture through the fibrous dysplasia lesion. So here's another view of the same lesion. Again, no periosteal reactions, no soft tissue masses, and just slight expansion of the bony canal, which means it's a slow-growing process. Okay, so points of discussion: you want to try to figure out how to diagnose these, how do we manage these fractures, and how do we manage this radial nerve palsy. So it's fairly simple. So it's a fibrous dysplasia type lesion. We are able to detect that just based on the imaging profile. You could get cross-sectional imaging just to be ensured that there's no soft tissue masses. And typically an orthopedic surgeon for a fibrous dysplasia lesion will go in, correct the lesion, bone graft, and then plate. Okay, it's recommended to use structural bone graft in these lesions because the bone itself, the bone metabolism in this region is sick. And if you use just autograft, then you're not really treating the underlying etiology. And you want structural graft because typically the disease comes back, and you want something that's more solid to allow it to hold and be in place. And overall, you just want the alignment and the bone to be functional with stabilization. And typically they heal very well, even after fracture. Okay. So in fibrous dysplasia, it's basically a ground glass appearance. There is some deformity, like in this image that will come up, a shepherd crook deformity, we call it. So it's just bowing of the long bones, and basically this ground glass matrix is the most important. Okay. This is just more features of fibrous dysplasia. It could come up as one lesion in one bone or in multiple bones, and then you have to think of syndromes like McCune-Albright, which has polyostotic fibrous dysplasia, café Leo spots, and premature puberty. Okay, so that just covers quickly an example of fibrous dysplasia. And the histology, I guess here we could just skip through that. Okay. Another case, A 19-year-old female, 3 months history of left knee pain, going up the stairs. Her knee buckles. She has severe pain and is unable to walk. Has a significant effusion, and she comes to the emergency room because she has a very tender medial condyle. Okay, you get X-rays, and you see this lytic lesion on the periphery, on the medial side of the distal femur, with obvious cortical destruction. But I'd like to point to the fact that you can even notice on this imaging that there's a neocortex. Okay, so a small thin layer of bone that's formed around this lesion gives you, again, as soon as you see that, it's a hint that this is a benign or benign aggressive type tumor. A more aggressive tumor would have very strong periosteal reactions. My colleagues will go over it, and soft tissue expansion, although here it is present. Okay. Typically in distal femur and the epiphyseal regions, things that you need to think about are giant cell tumor, and this is an example of a giant cell tumor that had a small pathological fracture. Here's a CT scan, again, a great example of the neocortex. I'll just wait for that to show up there. And then a fracture through the condyle. Okay? So these tumors are treated with resection, so curettage, very aggressive curettage. Some people advocate for neoadjuvant or adjuvant therapy, although more recent studies have shown that using these products do not really help in terms of recurrence. And people fill these gaps in with either bone, so again, cadaveric bone, and structural plate and screws, or cement. Okay. In some parts of the world, like in London, UK, this fracture would require an arthroplasty and a resection and no joint salvage. In Toronto, Montreal, we've shown that joint salvage can be very beneficial, especially in young patients, that we can actually save the joint and they actually end up healing. Although they have some recurrence sometimes, they still get to save their joints and ligaments. So for this case, we want to discuss what we said: diagnosis, the role of adjuvants, and then if we save the joint or not, and if there's local recurrence. But mainly, we fix these fix it with basically screws and hardware and bone graft. In this X-ray that's coming up, this is the same patient who actually had her joint saved, and this is on a follow-up X-rays, and she has full range of motion and able to ambulate. And you can see the suture anchors to recreate to reconnect the MCL. So it works very well, and you use structure as well as morsellized bone graft. Okay.
Does giant cell tumor typically go into the articular surface?
So it's on the epiphysis. So it's at the end on the basically past the growth plate on the subchondral bone that creates a joint.
Subarticular,
Yeah.
subchondral.
Yeah, subchondral.
Okay.
Again, this is just a typical example of giant cells. I don't think we need to go through that, but they're very rich in these multinucleated cells that you see on this histology. Okay, they're graded based on if they're contained within bone, if they're basically breaching the cortex but still contained by neocortex, or if they have a soft tissue mass, and that's called the Caponnacci grading system. Even that has been in recent studies, especially Toronto studies, have shown that this is not related to recurrence of the actual tumor. So the main goal of this is it's a benign aggressive, very rarely goes to the lungs, but has a chance of recurrence, and we try to do as much to save the joint and save the patient's mobility. Okay, so this is just other examples. This is a grade 1 lesion. Grade 2, you see that it's expanded past the cortex, but there's no soft tissue mass here on the MRI and CT. And then here's an example of a grade 3 where you see the anterior part of the tibia has some tumor. So just a slight delay here. But here you go. There is the anterior part where there's tumor. So the management's slightly different for these different type of grades. The higher the grade, typically the more aggressive we are with our treatment. Okay. I'm just gonna skip through this. This is more examples, and this is the studies that we showed. which basically show that pathological fracture does not increase recurrence rates. Using cement or other bone graft substitutes do not increase recurrence rates, and then the use of adjuvant therapy has not been really proven to decrease the recurrence of these lesions. Okay. Another case, 20-year-old male, the 4 months history of right groin pain. He goes to a chiropractor, manipulates his hip, and then he hears a crack. He's unable to weight bear, and obviously shipped over to the emergency department. And you guys see him. He has a shortened leg, externally rotated. Right away, you should ring a femoral neck fracture in a young patient, and this is his X-ray. So as soon as you hear a history like that, some manipulation but no real severe trauma, and he has a femoral neck fracture, or you suspect a femur fracture, automatically you should think pathologic, something pathologic is going on. So here you see is basically a rotated femoral neck fracture with a lytic lesion in the proximal and the greater trochanter and going up in the neck. Okay. Here's another view of this on the lateral. So right there, you should get a CT scan, so you should get local and staging in terms of cross-sectional imaging and see how extensive this lesion is. One, it helps you try to better understand the matrix of this, but you can see this is mainly a lytic lesion, and it helps you decide on when to involve the orthopedic surgeon. It's never a wrong idea to also get an MRI just to get a better idea and get your radiologist's opinion when you have these suspicions of benign lesions. But again, on those x-rays, you have a patient that has maintained the cortical basically shape and has a lytic lesion within it. So again, not very aggressive. An aggressive tumor typically destroys the bone and goes into the soft tissue, and it's pretty obvious. Okay. So for these lesions, we typically will, based on imaging, decide to actually go in and do an open biopsy and fixation at the same time, because they're pretty clear that there are benign tumors. However, these lytic lesions near the epiphysis or near the subchondral bone, you should always be careful of clear cell chondrosarcoma. So although 99% of the time we'll be right and this is a benign tumor, we always have to do a biopsy, because if it is a clear cell chondrosarcoma, it changes the whole picture and treatment plan. Okay? So if it's a benign tumor, we try to fix the joint and the bone and let it heal. If it's a sarcoma, you see it's a major resection and reconstruction.
You get same-day histology then when you're doing that? Or
yeah, so we actually we do a small opening. We'll grab some tissue, we'll send it to pathology, we'll look at it under the microscope, under frozen, and then if there is inconclusive, or they can't tell us for sure it's not something that's more aggressive, we'll actually halt the surgery and wait until we have a definite diagnosis. If they're able to tell us that it is, which is most of the time, they could see giant cells or other pretty telltale cells.
They're looking essentially for sarcomatous or carcinomatous cells, so
right.
either METs or primary sarcoma. And if you don't have any of those in the sample, then
we go, yeah. So that's what we did for this patient. So we did an open biopsy, and then we treated it just like a normal femoral neck fracture in an elderly patient, but we put in some bone graft. Okay. So I'll just skip through this. I'll go through one more case, and then I'll pass it over to my colleagues. So in another case, a 37-year-old male, pain in the left ankle. He's a marathon runner, tendon over the left malleable, a distal tibial diaphysis, and he has normal range of motion and no soft tissue mass or anything that you palpate on exam. And you get this X-ray, and it's basically a popcorn-like structure or a punctate formation within the medullary canal. So as soon as you see this type of sclerosing in the canal, you should automatically think of a chondroid type tumor, so cartilaginous tumor. And this is very typical of an enchondroma. So enchondroma are benign. They can be painful, And if they are painful, they warrant more investigation. If they're not painful, then you could follow them with serial radiographs. You can even get an MRI. Have a year elapse between a first MRI and a second MRI. If there's no change, you can completely ignore it. And if the patient becomes symptomatic, then you take it a little bit more seriously, get a CT scan and MRI, and plan for possible biopsy, because these can convert to chondrosarcoma or can be low-grade chondrosarcomas.
And something that people do is they try to get a bone scan for these, see if you can tell a difference between the chondrosarcoma or not. That's not true. So you can have an enchondroma that's completely benign and light up on bone scan. So it sort of gives you a lot of false positives. So the thing when you see an enchondroma is really the clinical symptoms that are associated with your radiologic findings.
This is a perfect example of this. So this is going to be a CT cut of this benign. This is an enchondroma, but you'll see the bone scan is pretty hot, right?
Yeah.
So it could be worrisome if you see that the first time, and you'd be worried. But if you do just serial radiographs and it doesn't change, it should be it's okay management. Okay, and we typically don't do much for this, and we will do a biopsies only if there's aggressive features, like John will go through in a bit, or if there's very symptomatic patients. They typically arise in areas where you'll have osteoarthritic changes and mechanical pain. So, for example, in this distal femur, they can have patellofemoral degeneration, and they can present with pain, and they incidentally find this, and then you get worried. So, again, just so you don't go too aggressively on treatment and referral.
What's your interval, sorry, for serial radiographs?
So typically a year's time frame between is what we recommend, because they rarely, even when they're low grade chondrosarcomas, they rarely will progress enough to cause a big problem or breach the cortex to cause problems in that time frame. But again, you go with patient symptoms. So if a patient comes in with extreme pain, then you take it a little more seriously.
And in the UK, it will be MRI,
Yes.
not,
Serial MRI.
not X-rays.
Yeah.
So you do an MRI, and then you do an interval MRI somewhere between 3 and 6 months, and you see if there's anything, and then you do another one maybe a year after that, so 18 months after your original scan.
And then if it's unchanged,
And if it's unchanged, then
just symptom based.
Yeah.
Is that the
Leave it
same
alone.
with radiographs or?
So I personally like that more, because it's a safer way to do it, an MRI, and then I would do 12 months between the two MRIs and make sure there's no change.
Yeah, I think an MRI at baseline followed by, and I think then you can follow with X-rays.
X-ray,
Yeah.
yeah.
Because if you have an X-ray and an MRI, and the X-ray looks and the MRI and your follow-up X-rays look the same as the previous X-rays, the MRI will probably look the same. Then there are any changes on the X-ray, then you would do the MRI. And the benefit of an X-ray is you can probably follow someone closer. You can see them at 6 months and get an X-ray, and see them at a year and get an X-ray.
They can have an MRI anyway.
Versus
I mean, an X-ray anyway.
yeah, you can have an X-ray anywhere versus getting an MRI each time. You can see how that probably becomes pretty problematic.
Right.
At least in the US.
But it's coming. MRI everywhere is coming.
Yeah. And then that's the most common tumor in the hands and fingers and feet. Okay. And then one last thing I'm gonna go through fast. Just osteochondromas are just growths off the canal that basically are connected with the intermedullary canal and can be pretty impressive, like you see on these X-rays. But you go again with symptomatology, and you get an MRI, and you look at the fibrous cap. I think people know that pretty evidently. And one last thing before I end is the UBC, so unicameral bone cysts. They do not require treatment even if they fracture. Most of the time they heal on their own. The treatment has been examined with different sclerosing agents and stuff, and what's been proven to actually help with this is just breaching the cortex and putting in the needle. So different adjuvants actually end up with the same type of treatment, and they heal well.
If they fracture,
Yeah.
they more than likely will go on to heal and then resolve.
Yeah.
That's probably a good thing. Just wait. And it won't heal if it's a malignant tumor.
Right. So I'll leave you with that. And the key telltale signs on X-ray is something called a fallen leaf sign. So you see a piece of cortex within this lytic lesion, and that's pathognomonic with a UBC. Okay. This is also different than an aneurysmal bone cyst, which is more aggressive and requires treatment.
Will
So
the aneurysmal bone cyst have a more of a regular outline, or?
So
It may
on-
just look
yeah.
identical.
Oh wow.
And even on
On
MRI,
X-ray.
the only thing you may see as a difference is the
Fluid levels, yeah, that's what you look for. But the radiologists will be pretty good at detecting that,
Yeah.
and they are more aggressive and require our intervention most of the time if they fracture.
Thank you very much. Who's next?